think we can open the session for questions for all the speakers.
When we're talking about telehealth aspect, a lot of us, not just us in Sugarland, we're using some technology to send our stroke alerts that have the capability for interfacing in a bigger way doing telehealth. Is there a benefit to, with the technology that's already there, make it happen quickly, to put the neurosurgeon on the telehealth with this stroke alert patient without having imaging, or are we really just doing something cool to say it's cool from the field?
So you're asking about potentially putting the neuroendovascular person on the telestroke sort of alert out in the field before. I would just say it's going to be similar to your example of whether you bypass a primary stroke center to go straight to a comprehensive stroke center, because a site like ours does a couple hundred of these cases, in a year, and across the system we're, doing many, many more than that, triple that number. And so if you think of activating and involving a neurosurgeon where there's less than 10% chance of probably having a large vessel occlusion, in the middle of the night, probably not the best use of waking them up. It's probably better to have a rested neurosurgeon for their interventions, especially prior to imaging. But then I'll highlight the importance of potentially a second step, which is, can you bring the teleneurologist out to the field? And I think that there's a lot of work ongoing with that, because that's sort of a funnel effect as it is right now. With some of the triage, we kind of really do rely on EMS triage and our ER physicians to help triage cases even before the vascular neurologist is involved. But I think that's something that we're really looking at, and I think that's where AI algorithms, these augmented intelligence triage algorithms, are really going to be able to help with the pretest probability of this being a stroke or a MEVO or a large vessel occlusion is really going to be able to help. And then the human can come in and sort of confirm those sort of findings to help triage the patients.
And I would want to join in this conversation. It's a very interesting conversation, and we talk about the entire system working together, and how making everything much earlier, much sooner. So all the data that we've seen with large vessel occlusions, with medium vessel occlusions, and recanalization is for patients whose arteries, the clots, have been exposed to TPA beyond 1 hour of the onset of symptoms. So now we also have data from different institutions all across the world and from mobile stroke units. The earlier you expose the clot to the thrombolytic, the better is the probability of lysing the clot much faster. So now when Dr. Kalafala made the case for transition to TNK, so we now know that with tenecteplase, the recanalization rates with large vessel occlusions are much better. So I think as the system transitions, we will see tremendous transition in the entire stroke model of care. So you'll have a vascular neurologist who can really expose the clot to the thrombolytic agent, maybe tenecteplase, maybe other agents, and you can do that, let's say, within 5 or 10 minutes of the onset of symptoms. So I've seen some patients where these things have been done at some different institutions, in Cleveland and in Germany, and by the time the patient shows up, you see a clot on CTA, but the clot is completely gone. So tenecteplase has tremendous potential, and the ability to lyse the clot, the sooner you expose to a lytic agent, is perhaps the best thing you can use for these patients, the fastest recanalization. And obviously now with robotic technology, clots which are resistant, the treatment time will be much, much faster. So I think as we combine all these treatments, if we choose to bypass a step, we are less likely to achieve the kind of outcomes we hope to achieve. Just to add to what Dr. Gardia mentioned. So any other question from the audience? Yes, please.
This is for Alex. The concept of recanalization versus reperfusion may be very subtle. And this idea, but when we get into the more distal circulation, it may become more relevant. There's this choice trial which used TPA after clot retrieval, and I just wonder whether you think there's a role for thrombolysis in the MEVOs or the more distal circulation, or just whether we need more innovations in the catheter, basically.
I think a combination of both. I've noticed anecdotally that patients that get TPA it makes the thrombectomy a little bit better, a little bit faster. I think there's always a risk of fragmentation, but TPA after thrombectomy, I think even though we remove the large vessel occlusion, there's still distal microvessel thrombus that I think the TPA really helps with thrombolysing and reperfusing. So yeah, I think I agree. Like TPA before or after, I think is a benefit for thrombectomy.
So I have a question, for all the stroke experts essentially, and this is a patient population. It's kind of unfortunate, but we do see that at Methodist because we have a big cardiovascular institute. We do all kinds of, aortic reconstructions. So these are individual, in my experience, and I think all the vascular neurologists would agree, that patients who have an aortic dissection, they get operated, or they come with a stroke because of an aortic dissection, and that is where we have limitations with the fact that we cannot use any thrombolytic agent. So what would what has been your experience as to how you would devise your endovascular treatment for patients who have, let's say, a type C aortic dissection, an aortic arch dissection, which may or may not take the origins of the great vessels? So in that situation, let's say I'm on call for telemedicine, we are flying this patient over, but we know that there's an aortic dissection, that is the cause of the stroke. So what would be your expertise, in terms of your recommendation as to how you would approach those patients?
Yeah, for a patient that we can't go through either the descending aorta, I think a good option is a transradial approach. So we've been starting to do transradial strokes here. So going through a catheter within the radial artery, bypassing the descending aorta. But for patients with where we can't approach the arch at all, I've been doing a number of TCARs, and I think a direct transcarotid approach is something that we could do here as well to bypass that ascending aorta.
So any other questions from the audience?
Thank you.